Welcome everyone, and thank you for joining us for the 7th session of the Leveraging Midwifery-Led Care to Address Disparities in Equity in Medicaid Virtual Learning Series. I am Jennifer Moore, the Founding Executive Director at the Institute for Medicaid Innovation. Before we begin today's session, we would like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in the Medicaid population. Through their generous and ongoing support, we are able to offer this free virtual learning series. Jumping into today's session, our presenters will provide information relevant to 3 main learning objectives that build upon the required activities that you completed before this session. They include learn how one state has implemented value-based models for maternal health through engaging Medicaid stakeholders, including state Medicaid agencies, Medicaid health plans, and providers. Identify the key requirements for launching value-based payment models and/or alternative payment models for midwifery-led care in the Medicaid population, including relationship building, data collection, and community engagement. And lastly, identify challenges and opportunities for implementing value-based payment models and/or alternative payment models for midwifery-led care in the Medicaid population. Before we get started today with our panel discussion, my colleague Lydia Tonkano will review a few housekeeping items.
Good afternoon and welcome to session number 7. I'm going to review some details for today's session along with a few reminders. First, today's session will be recorded and archived on the IMI and CHCS website. Except for panelists, all lines will automatically be placed on mute. During the meeting, the chat feature will be disabled for all participants. We have reserved time at the end of the panel for you to ask questions of our guests. Panelists, to participate in the discussion with the speakers, please use the Q&A feature to submit questions and comments. Please submit questions throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of each session, you will receive an email message with a link to complete a short 5-minute evaluation survey. As a reminder, completion of this evaluation is mandatory as part of your participation in the learning series. We actively review and incorporate your feedback into our future sessions. We look forward to hearing your thoughts in today's evaluation. Finally, all materials will be made available to you on the IMI and CHCS websites about 2 weeks after the presentation date. Dr. Moore, I hand it back to you.
Thank you, Lydia. So before we get started today, we wanted to provide background information on value-based purchasing and alternative payment models as a vehicle to support maternal health. As we think about value-based purchasing, there are 4 common approaches: pay for performance, bundled payments, shared savings risk, capitation, global payments. According to findings from IMI's recent Medicaid MCO survey, 86% of respondents implemented value-based purchasing arrangements with primary care providers. Respondents reported piloting various population-specific arrangements, including obstetrics gynecology. The most common external factors influencing adoption and innovation in VBP arrangements were providers' readiness and willingness, selected by 100% of respondents, and providers' information technology capabilities, selected by 79%. The most common operational barrier was data reporting to providers, closely followed by information technology system preparedness, support to providers to make determinations on value-based purchasing and alternative payment models, and tracking quality and reporting within a new structure. Respondents shared that opportunities for states to address barriers included improved state communication around value-based purchasing expectations, assistance in educating providers, and development of realistic, multi-pronged strategies for performance targets for specific populations and geographic locations. The CMS Healthcare Payment Learning and Action Network, commonly referred to as HCP-LAN, framework is oftentimes used to guide the development of VBP arrangements with an increasing number of state Medicaid agencies requiring VBP arrangements as part of their Medicaid contracting. Although some states have required MCOs to adopt perinatal VBP arrangements, including episodes of care, others simply require certain levels of VBP adoption by the health plans. In other words, leaving it to the health plans to determine which models to pursue, of which may or may not include perinatal focused models. The HCP-LAN has 4 categories with corresponding subcategories. Generally speaking, there have been mixed reviews with VBP arrangements in Medicaid. Some initiatives have reported increased cost without improvements in outcomes, and lower satisfaction with clinicians and provider groups. The experience of Medicaid programs specific to maternal health has revealed challenges related to designing and implementing episode payment models for maternity care, including whether to include the newborn or NICU in the episode of care, determining the VBP inclusionary and exclusionary conditions, and assigning an accountable provider. For example, the Arkansas, Ohio, and Tennessee Medicaid maternity episode models designate the delivering provider as the principal accountable provider for the entire perinatal episode, which can include up to 40 weeks before pregnancy and 60 days postpartum. Their episode payments are also reconciled retrospectively, or after the episode window ends, rather than prospectively assigned during the pregnancy. Retrospective arrangements are easier for both the payer and clinician provider group. The payment is triggered by the birth because this is the encounter that all have agreed is the event that confirms that the contracted clinician is accountable for the individual's care. The emphasis on the provider of record is intentional for the purpose of bonuses for quality outcomes achieved or penalties for things like a non-medically necessary C-section. This is referred to as an upside and downside financial risk model. It is important to note that the provider of record is responsible for the entire episode, including prenatal and postpartum care, plus labor and delivery. There is also a forced constraint on ability to manage a longer window of postpartum care for many Medicaid enrollees because individuals who become eligible for Medicaid due to their pregnancy will lose the eligibility at the end of the month that includes the 60th day after giving birth. Another major methodological challenge has been a lack of needed resources to address the gaps in evidence-based perinatal quality measures that drive improvements and reduce disparities. For payers, linking enhanced reimbursement to outcomes and costs can present a variety of challenges related to prioritizing investments. Administrative platform limitations such as data and analytics, claims payment systems, and provider engagement and reporting are oftentimes identified as a key barrier. Payers seek predicted return on investment and high volume practices with economies of scale to justify upfront capital investments to modify existing claims infrastructure. There is hesitancy amongst payers to implement a perinatal bundled payment program in the absence of high volume clinicians or provider groups. To support the infrastructure investment needed, consumer demand and patient volume needs to be sufficient to demonstrate a cost savings opportunity. This could be an opportunity where broad HCP land requirements could play a role, since states don't necessarily require plans to implement a perinatal payment program. Payers may also be reluctant to respond to the demand for bundles because there isn't enough service volume to justify the perceived cost of implementing the perinatal bundle. Furthermore, enrollment gaps and coverage churn can be destabilizing for a bundle. However, the inclusionary criteria could potentially address the issues with enrollment. Lastly, while bundles offer promise as an intervention, there is no one-size-fits-all value model that will meet the needs of every market. The need to adapt these models to local market characteristics adds another layer of complexity for payers, deciding whether to implement a value-based payment model for perinatal care. However, one resource offered through Prometheus, an Optum-owned product, provides infrastructure for bundled payment definitions that health plans can adopt. It is a universally applied model that helps clinicians and provider groups to streamline their efforts to meet one set of criteria rather than different criteria set by multiple providers. However, as a side note, IMI does not endorse or promote specific vendors or products. We only offer this information as one example. A bundled payment pilot in Texas led by the Healthcare Incentives Improvement Institute and Community Health Choice demonstrated how comprehensive payment can drive improvements in maternal outcomes and highlight some of the challenges associated with implementation. The perinatal episode was triggered by the delivery and included the following three components. First, pregnancy, 270 days pre-delivery, delivery, 3 days before birth until 60 days after discharge, and last, the newborn, birth until 30 days post-discharge. The pilot found an inverse relationship with the birth weight of the baby and cost of maternity and delivery, such that lower costs were associated with an important neonatal outcome. A key finding of the pilot was that even a few high-need, high-cost infants could strongly impact the overall cost and potential for shared savings in a bundled payment model. Specifically, model participants learned that the level 4 nursery designation for cost exclusion was not an effective stop loss for severity and cost. Some high-cost infants with birth defects did not require the level 4 designation and were, therefore, not excluded. This prompted the implementation of a stop-loss cap between $30,000 and $60,000 in year 2 of the pilot. So why consider midwifery-led care as part of VBP efforts? Midwifery-led care has been shown to reduce the number of interventions needed in labor and delivery, whether in hospital or in freestanding birth centers. As noted during the presentations by Dr. Dubé and Mr. Hill during the last session, the evaluation of the Strong Start for Mothers and Newborn initiative found that women served by midwives at freestanding birth centers had even lower risk levels and significantly lower levels of preterm birth compared to women receiving care in maternity care homes or group prenatal care. The Minnesota Birth Center, located in Minneapolis and St. Paul, has been successful in delivering high-value maternity care since 2012. Between 2012 and 2016, they delivered 1,096 babies with a 92% vaginal birth rate and a 70% vaginal birth rate after cesarean section, or VBAC, far higher than the national average. They also achieved substantial cost reductions relative to local hospitals, with an average combined savings of $11,954 for a vaginal delivery without complications and normal newborn charges. However, there are some barriers that need to be removed in order to fully support VBP arrangements for midwifery-led models of care. States can address the shortage of midwife-led care options in freestanding birth centers that face sustainability issues under current reimbursement policies and licensure requirements. Birth centers face a challenging financial model given low Medicaid reimbursement rates. On the flip side, commercial payers, who oftentimes have a Medicaid line of business, are interested in building payment models that incentivize use of birth centers for low-risk births, but find a shortage of birth centers to build an adequate network around. States can disrupt this chicken or egg scenario by mandating reimbursement and Medicaid fee-for-service, managed care organizations, and state employee plan contracts, and by reviewing licensure requirements to create a better business case for midwifery-led models of care in hospitals, alongside birth centers and freestanding birth centers. With the recent trends of hospital-based obstetric units closures in rural counties, leaving more than half of all rural counties without a hospital offering maternity care, exploring midwifery-led models of care that are led both by family practice physicians and/or midwives can help address this shortage. While not an alternative to hospital obstetric care for high-risk pregnancy, it could help to fill the maternity gap for many pregnant and postpartum individuals in rural communities. Examples of current VBP initiatives focused on maternal health that are led by various stakeholders, including state Medicaid agencies and providers, are highlighted on this slide. For the Medicaid population, I want to draw your attention to the purchaser or government category at the top. Tennessee is one example noted as having existing Medicaid VBP initiatives focused on a specific component of maternal health. Through Tennessee's Healthcare Innovation Initiative, the TennCare Medicaid program implemented a perinatal episode requiring Medicaid health plans to engage in VBP arrangements with maternal health providers. The episode covers prenatal care, delivery, postpartum care, and treatment of any complications or related readmissions. To date, the perinatal episode has saved the state $4 million in just the first year. All quality measures improved in performance over the baseline, including a 2.2 percentage point decrease in its C-section rate, a 3.9 percentage point increase in Group B streptococcus screening rate, and a 1.6% increase in its HIV screening rate, among other quality indicators. So the question before us today is how to build upon these existing initiatives. To help us learn more about the TennCare VBP initiative, including United Healthcare Community and States arrangement with a freestanding midwifery-led birth center, we have invited Mr. Sandwith back, along with two clinician colleagues, Ms. Conliffe and Dr. Buxton, to share more about their experience. We are also happy to have Tricia McGinnis, Executive Vice President at the Center for Healthcare Strategies, to return to moderate the panel discussion. Ms. McGinnis, I'm handing it to you to introduce our panelists.
Thank you so much. I am so pleased to introduce our panelists for today's session, focused on VBP purchasing arrangements and Medicaid maternal health. Dr. Margaret Buxton is a certified nurse midwife and clinical director of Baby & Company Birth Center, which is Nashville's only freestanding birth center, which is owned by Vanderbilt Health. She helped launch Baby & Co. from its early inception and on to when they opened their doors in 2015. I'd also like to welcome Ms. Kate Conliffe, who is the co-founder and chief executive officer of Diana Health, an end-to-end maternity care solution that helps hospitals revitalize their women's health programs. Kate has spent the past 2 decades working with companies and governments to scale high-value care models and improve health outcomes and lower costs. Prior to starting Diana Health, Kate was the chief operating officer of Baby & Company. And Mr. Michael Sandwith is Vice President of Network Development and Contracting at Aabc, Tennessee, a marketplace exchange product for Centene Corporation. Prior to joining Centene in 2020, Michael served as the Vice President of Payment Reform and Transformation for United Healthcare's Community and State Medicaid Health Plan in Tennessee. Welcome, everybody. Great. Hi, sorry for that pause. I had a bit of a glitch in my internet service. Welcome everybody. It's so nice to have you all here. Let's get things kicked off with a very brief background from each of you, just briefly for 1 minute. Tell us a little bit about your organizations and how you came to work with one another on a value-based payment model. Ms. Conliffe, do you want to get us kicked off? I'm sorry, Kate, we are unable to hear you. There you are.
Can you hear me?
Great.
Okay.
Yeah.
All right. So as I was saying, thank you everyone, and thank you Tricia for that introduction. My name is Kate Conliffe. I'm currently the CEO of Diana Health, which, as Tricia mentioned, is partnering with health systems to help them strengthen their maternity care programs, in large part by scaling midwifery-led models. Prior to starting Diana Health, I had the lucky chance of working with both Margaret and Michael at Baby & Company, which I helped to start and lead, and partnered with Michael in a value-based way in Tennessee.
Dr. Buxton, can you just share a little bit about what were the steps that led up to you all connecting with United Health Group, and then I'll turn it over to Michael to share a little bit about how he came to the partnership from his vantage point.
Yeah, since we opened in 2015, we were eager and anxious to secure our TennCare contract so that we could serve women who had Medicaid. We know that was, I think it's 50% of women have some form of support in pregnancy through that program. And we knew that they wanted access to midwifery-led care and they wanted access to the birth center option. So Kate and I worked carefully. It took us several years, I think, to get traction on that. But once we did, we were quickly looking for who we could connect with to set up a plan.
Great. And Mr. Sandwith, to tell us about where you came into the equation here when you were with United. How did you get connected with Baby and Company?
It was a dark Thursday night. No, I'm just kidding. Usually what happens, how we got connected was that TennCare has a number of different vendors that come and meet with them. And very fortunately, then TennCare will reach out to the managed care organizations and see if we have an interest in meeting with them and seeing if that might be a viable solution for TennCare. So TennCare made the introduction. I immediately set up the meeting, and that introduction was to all three MCOs, Blue Cross and AmeriGroup. But I just saw the importance of that, and that's how we started, them educating me and then me interacting with them of what we're going to need to convince United Healthcare to position that within our offering.
Great. Thank you all for that context setting. Now we're going to dive into the weeds because I know that's what the audience is very, very eager to hear from all of you on your different perspectives. So first, let's talk about some of the nuts and bolts of the VBP model. Ms. Collins, I'm going to first turn to you for this question. And could you just start by describing the structure and the methodology of the payment model that you landed on, some of the key issues around financial risk and the cycle of payment. And then I'm going to turn to Dr. Buxton to hear a little bit more about the quality measurement aspect of the model. But if you could kick us off, that'd be great.
Yeah, absolutely. So I'm going to split the answer into how we negotiated the contract versus how we structured the actual contract. And the reason is, well, so I'll tell you first about the negotiation. So we structured the negotiation assuming a bundled payment and shared savings model. So looking at the HCP-Led framework that Jennifer noted in her framework, it's sort of category 3A. And the reason that was important is because the biggest challenge for birth centers in thinking about expanding their services to a Medicaid population is that the fee-for-service rates really don't cover cost. And so what we were able to do in negotiating based on a bundled structure is really think in terms of the value that would be provided by the model. In Tennessee, we were lucky enough to have the state bundled payment program, which was not available to birth centers, but created a great set of benchmarks and a framework from which we could all start talking. So the contract, again, was structured and the reimbursement rate set based on a bundled framework where we negotiated a shared savings model upfront into the aggregate rates that would be ultimately contracted. We then contracted, though, based on a more traditional fee-for-service framework with a pay-for-performance element added. So we essentially took that negotiated aggregate revenue that we would expect across our panel of patients and allocated that back out to a traditional professional and facility fee based on a set of agreed assumptions, which is where the negotiation came in terms of how we were each bearing risk. What that meant in terms of payment cycle is that we were paid as we would be in a traditional fee-for-service structure at the end of the clinical episode for each payment, submitted claims post-birth and were paid subsequently. And then we had an annual review based on a set of agreed quality metrics, which I think Dr. Buxton will talk a little bit more about in a minute. And so there was essentially an upside payment that was agreed based on our achieving those quality metrics. In terms of how risk was shared then, during that upfront negotiation, we essentially agreed on the aggregate savings that the plan and the state would see based on the aggregate revenue that we would receive for our panel. And inherent in that were assumptions around C-section rate and birth center transfer rate. So in doing that, we were guaranteeing the state a set of savings and taking some risk ourselves in terms of our ability to manage the C-section rate and the transfer rate that were assumed in that upfront negotiation.
Really, really interesting. Dr. Buxton, I'm going to turn to you, but briefly just want to send a reminder to folks in the audience, please, as we are talking along the way, please enter your questions in the chat Q&A. We have 15 minutes set aside at the end of the panel to do that. I'm sure folks will have a lot of questions based on the deep dive. So building off of where Ms. Conliffe left off, Dr. Buxton, can you talk about the quality aspect to the payment model? You know, what quality measures were selected? You know, how they were tethered to the payment model. Can you sketch that piece, that really critical quality piece out for us a little bit?
Absolutely. From the beginning, as an accredited birth center, we were collecting data, and we did that through chart abstraction from the first time we saw that client all the way through prenatal care, birth, and through the postpartum care episode, so the closure of the episode. And we aggregated all of that through the Perinatal Data Registry, which is the data registry for accredited birth centers in the US. And so what that gave us a chance to do was benchmark ourselves against other birth centers, against national benchmarks, but also query that data. And we reviewed it monthly and quarterly and annually, but we were looking sort of at our personal trends as a birth center and then within our own network. And so when it came time to negotiate, we had a lot of data on tons of different metrics that we could share. We had good historicals, but, and then we also, of course, had a way to track moving forward the health outcomes for our cohort of clients.
And were there particular measures, you know, or there are specific measures that you wanted to make sure that were part of the bundled payment that you would highlight for folks in the audience that you think are just particularly critical for, you know, helping you ensure and drive to better health outcomes? Any, you don't have to tell us all the measures, but any that you would highlight in particular that they are really valuable?
The highlights, of course, were our cesarean section prevention. So low C-section rates, low rates of preterm birth. We looked at NICU admissions. We looked at breastfeeding rates, entry to care, transfers out, all of the things that we know, you know, are metrics that you can really make a difference in health, morbidity and mortality for women and for infants.
That's great. Thank you. Mr. Stanowith, I want to turn to you from your perspective on the payment piece. You know, Jennifer did a really excellent job kind of giving the broader national landscape on perinatal episodes of care. How, you know, from the health plan's perspective, like how is this payment model different? Like how is it what were some of the ways that you structured the payment model to really tailor it to a freestanding birth center, you know, midwifery-led model? Can you tell us some of the highlights that were really critical from the plan perspective that you were able to build into the payment approach?
Sure. I mean, initially what we had was a base. We had already done episodes. So for perinatal, so to expand that, and the way I look at bundles, you expand it according to sites of service or risk of women. So I was also at the same time trying to develop a high risk episode for those of addiction or other means. So we had a good foundation. The humorous thing, I love the finance people, the contracting people, the initial dollar amount that they threw out there, I just went, what? It was extremely low. And so I said, there is no way you could perform what you're asking to do in a quality, a value-based program. So I researched, I have all the data of all OBGYNs in Tennessee. So I researched some of my most successful OBGYNs and what they came in with total costs and what their quality measures were, because I had all the confidence in the world that Baby and Company could deliver because they had the data. They had the people, they had the support. They just had a fantastic program. So to me, what I had to do was align their value with the value of the health plan. And so we'd already done episodes. So it was just an aspect of making sure what went into the perinatal episode captured what needed to go in for Baby and Company. On the metrics, there are only 3 metrics for perinatal: C-section rate, HIV, and I forget the other one. I think Jennifer talked about that. But that really didn't make sense for baby and company. We had to look at what were the quality measures that we as a health plan who knew nothing about birthing centers. I mean, I can tell you, I was the only one that was above an 8 in knowledge level. Everyone else hovered around 0 to 1. So we had the data, we had a model, and then we partnered together to make it work, to create an episode of care that, one, could be administered by United, and 2, we could get the reports out. And it just happened to be what I call that perfect storm, where we had data, we had history, we had a model, and we had collaborative partners that came together to create a solution. And that's what's key, is it can't be healthcare driven. It has to be collaboratively driven by those that are delivering care. So that's kind of how it. I had the easy part. So they had already accumulated the hard things, because we have a lot of vendors who come in and tell me how great they are, and usually they give me the first slide is how much healthcare is costing the U.S. And I go, okay, I got that. But really, what is it that you're trying to deliver? Baby and Company showed that, and I just kind of directed them along that line.
Can we, and that's what I want to drill down into next. We've given this overview of the payment model, and I would love to hear, each of you briefly talk about how to understand the design process and some of the critical components to that process. So, Mr. Sandwith, from you, can you talk, give us a sense of, from a relationship and engagement perspective, how did United, were there specific activities that you had to engage in as a champion at your health plan to support Baby and Company in the process that you would highlight for other plans to be aware of that were really, really helpful in shepherding the birth center through the contracting process? What's one or two things that you would point to?
Well, the uniqueness of this relationship is I built the episodes of care programs for TennCare. I had to take the models from McKinsey and we had to implement them according to TennCare standards. So I already had an advantage because I knew the program. What I did outline is in our initial meeting within United is basically kind of just told them, hey, we've got to tell a story here and data has to be part of that story. So it became a 2 or 3 meeting process. First meeting was, this is Baby and Company, this is what they do, this is what they have. And then I read the room, knowing that I was going to be the champion, but still read the room to see, could we move forward? And so we elected to move forward. And finance asked for specific things. The CMO asked for certain things. And I'll send a product positioning checklist for people to get the details of that. But basically what I was doing was making sure every question was answered along the way, and then moving it along to contracting. And then I even played a role in negotiating the contract, which, because I saw where they were going with that. So really my job was, I knew the product, I just had to get it through the process to get approval. And I had to tell a story at every meeting of the value of what it was providing. And clinical got it, CMO got it, other people got it. So it just kept moving along till we got to the end point. Okay, Mike, what's the rate and how are we going to measure Baby and Company? And that's why we came up with separate quality measures for that. And I can send that list, because I'm a pack rat. I can send that list of what we came up with. because more I look at it, we were so far ahead of the game. It was amazing what we were listing as our metrics that we were going to report back. So
Yeah, that's
and
great. And I
easy-
know, yeah, and I know that the audience will find those details incredibly important. So appreciate that follow up. Ms. Conliffe and Dr. Buxton, I want to turn to you for your perspective on the negotiation and contracting process and what you learned along the way. I mean, obviously, Dr. Buxton, you talked about the data that you all had been collecting all along, which was clearly a key facilitator. What did you learn along the process of negotiating a contract with a health plan and Medicaid that in terms of skill development and what you needed to do that would be helpful for others in the audience to hear about?
I think the most memorable thing to me was touring the team in the birth center and showing them sort of the lived life of a bustling birth center with people coming in for prenatal care, someone just giving birth, showing them the environment of care, which that specific model of care is rich with time and relationship. And those two things are the driving force behind the sort of resilient outcomes that we see that look so desirable. When you build relationships, you help calm people down and steady them. They come back. They're more likely to access care, and with shared decision making, you get those less risky interventions and outcomes along the way. So when we were in the negotiating process, it was more about showing than telling. And that was a unique experience. And I think it was very valuable.
For me, I think there were sort of three key takeaways from this experience. The first is just a timeline note for other providers in the audience, which is that, as Margaret sort of highlighted initially, this was a multi-year process for us. And the most important thing was finding Michael, finding the champion, but that's from a provider's perspective, that's like finding a needle in the haystack. So, we spent probably 12 to 18 months up front, including having the chance to meet with Governor Haslam's office in order to get to Michael. So building in those timelines up front is important. The second thing, and we've highlighted this, is how important it is to have good data and to tailor it. Both our own data was really important, and Margaret talked about that, but also having strong benchmark data. So we did a lot of research up front on what we thought the relevant costs of care were, what we thought the relevant quality benchmarks were, and what we thought the state cared about, so that we could build a strong business case. And then finally, the importance of sort of follow-up and momentum. As Michael talked about, there was sort of a two-phased process with United, which was sort of building the business case up front and getting to yes, and then moving to contracting. And both of those processes took time. And there was sort of a gap in momentum as we moved to contracting. So really making sure that you're continually following up and building that business case with data across the process.
That's great. Those are really practical words of wisdom for folks. That's terrific. So you've implemented the model, and I think everybody's really eager to hear, like, what were the results? Tell us a little about sort of the quality results, like any changes that happened as a result of the model. Kate, Ms. Conliffe, maybe we should start with you. Hearing about, we've talked about, I would love to hear how this approach to payment has worked better than a more traditional fee-for-service. Like, what are the practical ways that the payment model has enabled you or enabled Baby & Company to do its work more effectively? Or I'd just love to hear from kind of the payment side. And then Dr. Buxton, I'll turn to you to hear more about some of the quality outcomes that have been the result.
Yeah, I mean, I think if you'll allow, I might even reframe the question to say it's not just better, but it was necessary. In other words, we did not provide access to the Medicaid population in Tennessee before we had this contract, because the traditional fee-for-service rates were significantly below cost. And so we just weren't able to do it sustainably. And so it was by negotiating, as I mentioned, based on that bundled approach that we were ultimately able to increase the aggregate revenue rate to a place where we could sustainably provide service and do it in a way where we built in enough guarantees to the state that they were going to see the value for that, both from a savings and quality perspective.
And Dr. Buxton, what about what kind of quality results have you all been able to demonstrate? So can you shed some light? I mean, you were already doing fabulous work before expanding into the Medicaid space, but tell us a little bit about what that. I mean, that was probably a very different shift, right? All of a sudden, bringing in Medicaid patients into the practice. So I'm curious about the quality results.
Yeah, as we ramped up enrollment, we sort of steadied out at about 20% of our client base having Medicaid. So that gives the audience a sense of what we're talking about. And we were doing, approximately 50 to 60 births a month between the birth center and the hospital. We were, giving people the option for delivery in either location. Within the birth center setting, what we were able to do was really sustain those low intrapartum C-section rates, which hovered around 6% for the birth center. And then preterm birth rates, tracking that incredibly low between those years that we sort of changed our population of women. Essentially, the story is that we sustained really a desirable health outcomes. And one of the hallmarks of our program of care is early access in pregnancy. And I know access in the first trimester can really make a difference in the trajectory of a woman's health. So we had a primary prevention screening program that was specifically looking at who is at risk for preterm labor, high blood pressure, or gestational diabetes, and can we target wellness education from that first contact and track them carefully to improve the health outcomes in pregnancy. And we were able to show with data that we did make a difference in those areas. And that all of those, programs are still in place today, and we're continuing to track our data. And more importantly, I think for us, it was this huge win in the community because women wanted options. And we didn't want this sort of like, only if you have private insurance or you have a lot of cash can you have this birth center option, but everybody gets options and everybody can have access to this midwifery-led model of care that was so desirable.
So that leads me to my final question before we open it up to Q&A. And you all have all touched upon this a little bit, but I really want to focus intentionally on the equity angle. Because the potential that this model has of really addressing the horrific disparities that we see among women of color in birth outcomes. And would love to hear your thoughts on, how, one, it's great to hear that basically you were able to produce equitable outcomes from the Medicaid population that you were already having in other payer populations. But more deeply on the racial health equity perspective, would love to hear more from you on what you think the benefits of the model are from a racial equity perspective, and specifically how it intersects with the payment model, if at all, and how if the payment model isn't explicitly incentivizing health equity, are there ways that you're thinking about the payment could be strengthened with more intentionality around the equity piece? But just broadly speaking, would love your thoughts on how payment is intersecting with the need to really ensure better health outcomes for women of color in birth.
Margaret, do you want to go first? Or
I didn't know if it was directed at me directly.
At both of you, yeah. Sorry, both of you, yeah.
Yeah, I think, really what was disturbing to me was just, talking to women of color in the community and hearing from them prior to the instituting this program that they felt like the birth center wasn't for them. And so being able to, level set that, all women having access, and then really demonstrating this healthcare model that was built around relationship and trust, and how that changes outcomes and develops positive healthcare experience. And then from one of the things that Birth Center does really well, all birth centers, is they stay connected with their clients and they build community. And what we saw was an incredible increase in the diversity of our birth center family that, you know, with their babies, and we're able to do community events and outreach. We had ambassadors in all different parts of the community talking about this option, and that really hadn't existed as strongly as it did. And that was incredible to see, and it's very inspirational.
Yeah, I think for me, the way that the payment model as it was constructed is linked to equity is sort of relates to the broader points that we've been talking about, which is that what the payment allowed us to do was invest more heavily, as we do in the birth center model, in an enhanced prenatal care program where we're investing in relationships, which is about time and responsiveness and really putting the structures and the systems in place to make sure women's voices are heard. So I think that's the major way, is it gave enough financial flexibility to do that. As we think about how it might be strengthened going forward, I think some of that is through measurement. So we report out today on a set of key measures across the population base. We don't stratify the data today. I mean, we did at Baby & Company internally, but relative to what the relationship that was set up with the payer, that was not in place and could be going forward as a way to make sure that we're following through on our promises to patients.
Great. Karen, I'm going to hand it off to you to moderate the Q&A from the audience.
Thank you so much, Tricia. We do have quite a few questions, and I'm so happy to say that in the course of the discussion, many of them have already been answered. But let me start with you, Kate. With regard to the measures, how were those measures actually defined in terms of their numerator and denominator? How were they reported? So for example, were they self-reported to the health plan? Were those measures extracted from claims that were submitted to the health plan? And then how were they then reported back to you in terms of achievement? If you could just talk a little bit about that process.
Sure. Yeah, so the data was, and I think still is, though Margaret will have to verify that, but still is self-reported. It's data that comes out of our EHR, and as Margaret said, we report to United, but also to the Aabc through the PDR process and to others. I'm going to throw it back to Margaret to help define the numerators and denominators specifically, but yeah, does that answer your question, Karen? Is that what you were looking for?
Yes, thank you. So those measures were defined by the prenatal database and Aabc, and you use those definitions.
Absolutely. I'm sorry. Yeah, I didn't understand that part. Yes, absolutely. We, in general, try to rely on well-defined measures so that we can have verified benchmarks to report against. It's really important as we think about growing a relatively nascent model of care, or one that we want to scale, that we have good benchmarks to compare to so that we can make the business case that we've been talking about.
And Margaret, did you want to follow up?
Yeah, just to highlight the core data set for the Aabc, which is based on enrollment into care. So from that first visit, we're tracking people who transferred out, and all, you know, or if they finished with us, all of the data across it, and that's how we get that denominator to look at the different metrics.
Mm-hmm, mm-hmm. And I do have another follow-up for you, Dr. Buxton. You mentioned earlier about the good work that you were doing with regard to improving upfront education that resulted in some quality improvements for those patients being seen at the birth center. Mm-hmm. If you could choose maybe one measure, two measures, maybe primary C-section rate, VBAC rates, maybe NTSV rate, if you could think about one of those measures and what improvements you might have seen in those measures, and how those improvements were brought about. What did you actually change with regard to your practice?
We had a wellness-based program. So essentially, enhanced prenatal care means, you know, so you had the minimum standards of certain amount of visits, testing at certain screening points, But what we did was start with a lot of education-rich resources for our clients, reiterated in the prenatal visits around lifestyle changes. So how do you see, rather than giving people a list of things they can't do now that they're pregnant, we said, what can you do? Well, this is what, this is the science behind the healthiest diet, and this is the science behind the healthiest types of movement and exercise. And again, not just a handout, but a conversation about sleep, nutrition, movement, stress levels. And then we had backed it up with all of these education modules that we offered in different formats for people. That really ultimately made the difference. At the end of the episode of Care Towards Getting Ready for Birth, we talked honestly about, what the science says about elective induction versus waiting for labor to start, those kind of conversations that start to impact the episode of care in significant ways for reduction of the cesarean section.
Mm-hmm. Well, thank you very much. I appreciate that. So interventions, not only for those that you served, but for the providers themselves as well.
Absolutely.
So for Mr. Sandwith and Ms. Conliffe, I have a question for you. To the extent that you can share this information, from a financial standpoint, how was the implementation of this bundle payment model financially successful for the health plan? And was it financially successful for the birthing center in terms of being able to cover costs for Medicaid patients? So Michael, why don't I turn to you first? And if you could give us a brief answer, we'll turn to this.
Yeah, I'll do real quick. Really, for me, the motivation, there were three things. One was the motivation to open up another side of service for a Medicaid woman to have a birth. That was my driving aspect, because as others have said, it was closed to them and they wanted that option. I even went out and did some focus groups at Meharry Medical Group and Nashville General Hospital about that as well. So that to me was the driving force. Financially, with the episode, this had to be a collaborative win-win. It wasn't going to be what contracting started out to be, was a lose-lose. Because what happens is they contract and that's it. That's the last you'll hear from contracting with that. So for me, I wanted to make sure we started off, and I remember the conversation, is we'll start off with this. If we can make this work, we'll put the measures in it, but we'll come back and look at it once we get more data about cost. So I included that we'd go back and look at it to make sure that it was going to be financially aligned with baby and company.
Mm-hmm.
And really, once we were done, I was the only one that kept track of it. Nobody else. It was done, contracted, and we moved on.
And Ms. Conliffe?
So a couple things, I mean, without revealing specific rates, obviously, but we have the benefit in Tennessee of having publicly available data on what the average payment for maternity care was. And at the time, the acceptable threshold for the state, I think, was nearly $8,000, $7,700 for the episode. So what we did up front, as I mentioned, is negotiate an aggregate rate that ensured a savings for United relative to what they were paying otherwise. And essentially what we did is to say, today we're not serving a Medicaid population. So these patients would otherwise be going to the hospital and you would be paying this rate, and we will negotiate a savings relative to that. And then we did it in a way where we were comfortable that we could then cover our costs, which was really what we were looking to do as we thought about opening up to a Medicaid population. And in one of the pre-reads for this session, there's a paper from the Aabc called Getting Payment Right that has a very good table in it on page 24 that really outlines for you what the cost to serve a patient using the birth center model looks like. And it outlines that for a birth center serving 300 patients, that's a cost of $7,500. So, just as you think about that sort of balance that Michael talked about, that's sort of what we were thinking about as we tried to negotiate the rates up front.
Mhm. And thank you so much. I think we've got a couple of more minutes left to our Q&A session. Dr. Buxton, I have one for you. What types of community engagement are most successful for marketing midwifery-led care?
Thank you for asking that. For us, really, it boiled down to grassroots, figuring out who the community leaders were that were embedded, who may not identify themselves as leaders, but truly were the influencers in terms of the childbirth professional community. And within that grassroots effort, listening to what people cared about, what they were worried about, and becoming embedded in different parts of the city and sort of different pockets of communities. We did that with our own outreach, but we also did that through, like I said, parent ambassadors, people who had a really good experience with their birth, and we called them our super fans, but we were sort of like, we wanted representation in the community, and we wanted diverse representation. So thinking about marketing, not so much in the traditional sense, but like really being a reflection of the community itself.
Mm-hmm. Excellent.
And I'll add one quick thing, is we as the health plan had to do our part. And I always had summer interns. And so I had my summer interns develop the marketing plan for Baby and Company, not only for them, but for United Healthcare, so that we could educate our members about this new option. And so we did a series of newsletters, email blast out. So we had to step up and communicate to our membership that this was now a viable option as well.
Mm-hmm. Thank you so much for that follow-up. It's clear that there was a very high level of collaboration between these two organizations that led to the success. Okay, I have one more minute, and Kate Conliffe, will allow you to close out the session with this question. What were the key elements of the business case that Baby and Company presented that ultimately resonated with the state and then United Healthcare Community State Medicaid Health Plan? Just a few of those key elements. I know you talked about it briefly, but.
Yeah, I think it was simply that this was a model of care that meets the triple aim. It's one that can drive significant savings for the state and for the plan. It's one that improves outcomes measured by C-section rate, preterm birth weight, and really any perinatal measure that matters. And it's one that improves the patient experience, and we had good NPS and other scores to validate that. And of course, that was said with much more data and specificity to the different players we were engaging with at the state, which is critical, but that's really the top line message that ultimately, I think, made a difference.
Thank you. Jennifer?
Right, thank you. What a wonderful conversation with our panelists, and great questions from the participants. Just as a reminder to all of you, if we were unable to get your question today during the Q&A, we will be sending the questions to our panelists and giving them an opportunity to respond as part of an FAQ document that will certainly be shared with you about 2 weeks after this session, and an email as part of our post-session wrap-up. With that, I'm going to hand it off to Lydia, who will go over a few other wrap-up items before we close out today's session.
Thank you. At this time, everyone should have received an email with the link to complete today's brief 5-minute session evaluation. If you did not receive the email with the session evaluation, please contact me. My email is listed on, I believe it's going to be, on this slide. We will be sending the presentation slides, session Q&A document, and archived recording of today's session by email to you within the next 2 weeks. Finally, our next session is scheduled for May 14th and will be focused on the roadmap for success, action steps for launching high-value evidence-based maternal models of care. Keep an eye out for the pre-session email with the agenda and required pre-session activities. If you haven't already, please remember to add Jennifer Moore to your email contact list to ensure that the series emails are not sent to spam. Her email is also posted on the slide. Thank you for your participation. We look forward to your participation at the May session.
Thank you, everyone.